In order to make EKGs easy, we're going to walk through one cardiac cycle, and as we do that, we're going to draw out the EKG line, and it's all going to come together. So there are two main phases to the heart. There's diastole when the heart's at rest and it's filling with blood, and then there's systole when the heart's squeezing and pumping blood forward. Let's start with diastole. This is when the heart's at rest, so the right ventricle and left ventricle are going to be in a low pressure state because they're at rest and not squeezing. This is going to allow blood to enter the heart. So blood from the superior and inferior vena cava will enter the right atrium, and blood from the pulmonary vein will enter the left atrium. As blood enters the right and left atria, it's going to build up the pressure in the atria. Well, remember we just said that the right ventricle and left ventricle are in a low pressure state, so the pressure in the atria is going to increase relative to the pressure in the ventricles, and this is going to allow blood to start to flow from the atria down to the right ventricle and left ventricle. So if we apply this to an EKG, we have a perfectly flat line right now. And the reason for this is there's no conduction or electricity going on. There's no contraction of the heart. Right now, this is passive blood flow based off of differences in pressures. Here's where things begin to change. As blood accumulates in the ventricles as indicated by the black line, it's going to increase the pressure of the ventricles. Well, now that ventricular pressure is going to be increasing relative to the right and left atria. So the atria are going to need to squeeze and contract to increase their pressure to allow blood to flow from the atria down to the ventricles. And this is where the conduction system comes into play. The conduction system starts at the SA node, which sits in the back of the right atrium near the superior vena cava. The SA node is made up of pacemaker cells that can generate their own action potentials. There was a previous EasyMed video that made cardiac action potentials easy, and I'm going to link that above, and I encourage you to go check it out. When the SA node generates an action potential, that action potential will travel through the right atrium and depolarize it. It will also travel through Bachmann's bundle to the left atrium and depolarize the left atrium as well. This depolarization will lead to atrial contraction, which will increase the pressure of the atria and allow blood to flow from the atria to the ventricles at the end of diastole. So if we go back to our EKG, we now have electricity or conduction going on in the heart. So this is going to change that flat line on the EKG that we already have. And this is when the P wave comes into play. The P wave represents atrial depolarization that causes atrial contraction. The action potential generated by the SA node then enters the AV node, which sits at the base of the right atrium. The conduction velocity is slowed at the AV node to allow for time for the atria to contract before depolarizing the ventricles. So if we go back to our EKG, we have another flat line again. And the reason for this is because that AV node is slowing down the conduction velocity before depolarizing the ventricles. So that flat line is going to represent the slight pause that occurs between atrial depolarization and ventricular depolarization, which we're going to talk about now. The action potential will then work its way down to the ventricles, and it will do so by exiting the AV node, traveling through the bundle of His, through the right and left bundle branches, and end in the Purkinje fibers. While the action potential is traveling through this part of the conduction system, it's going to be depolarizing the ventricular myocytes, which will lead to ventricular contraction. So if we go back to our EKG, we now have myocytes that are depolarizing again. So there's going to be a change in that flat line, and this is when we get the QRS complex. The QRS complex represents ventricular contraction. This is the transition from diastole, in which the ventricles were relaxed and filling with blood, and systole, in which the ventricles are now contracting. As the ventricles squeeze and contract, it's going to increase ventricular pressure. Well, once the ventricular pressure surpasses the pulmonary artery and the aorta, it's going to allow for blood to flow forward. So the blood from the right ventricle will go through the pulmonary artery and enter the pulmonary vasculature, and the blood from the left ventricle will go through the aorta and enter the systemic vasculature. So if we go back to our EKG, there are no new changes to the voltage of the cardiac myocytes. They're still depolarized. So we're going to go back to a flat line here, and that's going to represent the time between ventricular depolarization and ventricular repolarization. As the blood is being ejected out of the right and left ventricles, it's going to start to decrease the ventricular pressure. In addition to that, the ventricular myocytes are going to start repolarizing, so they're going to start relaxing again. This is going to further decrease that pressure in the ventricles. Once the right ventricular pressure falls below the pulmonary artery, it's going to close the pulmonic valve. And once the left ventricular pressure falls below the aorta, it's going to close the aortic valve. And this is going to stop that blood flow from exiting the right and left ventricle. So if we go back to our EKG, we now have ventricular repolarization. So again, we have a change in voltage of the myocytes. So this is going to be reflected on the EKG, and it's represented by the T wave. So the T wave reflects ventricular repolarization. The heart is now in a relaxed state, so that brings us back to diastole. If we go back to our EKG, again, there's no changes in voltage of the cardiac myocytes, so we're going to have a flat line again. And that takes us back to that first line that we started at while we wait for the next P wave. So let's go ahead and summarize this. We started off with the heart being in diastole, and we started off with a flat line on EKG. This was because there was no changes in voltage to the cardiac myocytes. We had passive blood flow from the atria to the ventricles based on differences of pressure. Well, once the blood started to accumulate in the ventricles, the ventricular pressure increased, so the atria needed to contract to increase their pressure to allow for blood to flow from the atria to the ventricles. And this atrial depolarization and contraction was reflected by the P wave on EKG. Remember that it was the SA node that generated the action potential and allowed for atrial depolarization to occur. The action potential then traveled to the AV node where the conduction velocity was slowed to allow time for the atria to contract. This was reflected on the EKG as a flat line between the P wave and the QRS complex. The action potential then traveled through the bundle of His, the right and left bundle branches, and ended in the Purkinje fibers. While the action potential traveled through this part of the conduction system, it allowed for ventricular depolarization and contraction to occur, and this was reflected in the QRS complex on EKG. There was then a flat line between the QRS complex and the T wave, which represented the time that the ventricles were depolarized. Eventually, the ventricles repolarized, and this was reflected on the T wave, which brought us back to the beginning of the cycle again. I do want to point out that you'll notice there was no specific wave that represented atrial repolarization, and that's because that occurs during ventricular depolarization, so it's tucked away and hidden in that QRS complex.